The system can be used in combination with a tricortical bone graft or a vertebral body replacement such as Synex. The instrument set is equally suitable for open, minimally invasive, or endoscopically assisted approaches. The procedure shown here corresponds to an endoscopically assisted approach. Telefix can be used from T8 to L5 in fractures that can be adequately reduced and secured from anterior, tumors and infections, post-traumatic kyphosis that can be adequately reduced and secured from anterior, and posterior fixation requiring additional anterior stabilization. Telefix is contraindicated for severe osteoporosis and scoliosis. The implant combines the advantages of plate and rod systems and is pre-assembled for easy handling. The telescopic mechanism allows simple adjustment of the length as well as compression or distraction when the implant is in place. The implant has a low profile to help preserve the soft tissues. The polyaxial spherical bushings allow insertion of the blue posterior screws according to individual anatomical needs. The plate is secured onto the posterior screws with the locking screws, giving angular, stable locking to the bushings. The green self-locking anterior screws have a stable angular anchorage in the plate itself. On the model of an L2 burst fracture, bisegmental instrumentation from L1 to L3 is now demonstrated. To position the posterior screws, the aiming device, the tappet, and the Telefix K-wire are needed. The K-wire is screwed onto the tappet and then inserted into the aiming device. Each marker ring on the tappet corresponds to an impaction depth of 10 millimeters. The maximum depth of impaction is 30 millimeters. Under image intensification, the aiming device can be aligned onto L1 to insert the K-wire parallel to the posterior wall of the vertebra. The aiming ring is seen under image intensification. It has a diameter of 16 millimeters and can be used as a positioning aid. The ideal point of entry is found when the ring is touching the posterior wall as well as the end plate of the vertebra. When the K-wire appears as a point, it's aligned parallel to the beam of the image intensifier. Using the slotted hammer, the K-wire is driven in. The normal depth of impaction is 20 millimeters. The tappet is unscrewed from the K-wire and removed, together with the aiming device. The second K-wire is inserted into L3 according to the same procedure. The cannulated awl is used to open the cortex. The required depth of insertion, usually 10 millimeters, is set with the adjustable stop on the scale. The awl is introduced into the posterior drill guide and slid over the K-wire. Care should be taken to ensure that the foot of the drill guide is pointing to the other K-wire. The cortex is opened with rotary movements. The same procedure is performed on L3. A screw extension is mounted onto the cannulated self-holding screwdriver. The screw extension is then placed in the top of a blue posterior screw. The required length of screw was determined from the preoperative CT scan. The screw is passed through the drill guide and over the K-wire. It's inserted only until it's firmly seated in the bone, usually after 2 or 3 rotations. The K-wire is then extracted. To remove the K-wire, the extraction rod is passed through the cannulated screwdriver and fixed to the K-wire. The extraction rod along with the K-wire is then removed. if necessary with the aid of the slotted hammer. The screw is now inserted deeper until the appropriate marker ring on the sleeve of the screwdriver meets the top edge of the drill guide. To extract the screwdriver from the screw while leaving the screw extension in place, the push-off sleeve of the screwdriver is pressed down and the screwdriver is removed. The second posterior screw is inserted into L3 using the same technique. The fractured vertebra is removed, together with the adjacent intervertebral discs. A tricortical bone graft or a vertebral body replacement, such as Synex, is used. The AO Synex video contains more information. To ensure that the correct implant is selected, the spacing between the two posteriorly located screws is determined using the ruler for Telefix. The appropriate implant is selected according to the size indication on the implant tray. The drill guide for Telefix is mounted onto the caudal plate hole for the anterior screw. The implant holder is introduced through the drill guide and screwed into the plate hole. The spherical bushings must be aligned perpendicular to the plate and the telescopic mechanism released. The Telefix implant is positioned by sliding the bushings over the screw extension mounted on the posterior screws. The implant is held firmly against the bone. The cannulated screwdriver is attached to the first screw extension and locked in place by pressing down and simultaneously turning the push-off sleeve clockwise. The screwdriver, together with the screw extension, now is removed. The posterior locking screw is inserted using the cannulated self-holding screwdriver, but it's not fully tightened. The screw extension of the caudal screw is extracted. The second posterior locking screw is inserted. The two locking screws are now firmly tightened. The implant holder is removed, but the drill guide is left in place. The cannulated awl is used to perforate the cortex of L3 for the green anterior screw. The depth of penetration is preset with the stop on the awl. In most cases, 10 millimeters are sufficient. The anterior screw is picked up with the self-holding screwdriver and inserted through the drill guide. The screw is aligned by the drill guide, and the screw is self-locking in the plate. The drill guide is placed over the second anterior plate hole. The cortex is perforated, and the second anterior screw is inserted in the same way as the first one. The Telefix implant spreader is used both for distraction and compression. Turning the handle clockwise produces distraction, and turning it anti-clockwise generates compression. The hexagonal screwdriver with tip is inserted through the implant spreader and into the screw of the locking mechanism. The spreader is opened, and the pin of the slider is set into the cranial hole of the implant. Compression, of course, is achieved by turning the handle anti-clockwise. The locking mechanism is now secured. The implant spreader is released and removed. All the screws, including the locking mechanism screw, are checked and fully tightened.